Hello and welcome, and thank you very much to Raja Mukherjee from the Adult ADHD Service in Surrey. So yeah, we're going to ask you a lot of questions that have come from, a couple have come from myself, but most have come from our Facebook page. So the first one is, why 3 years later, you know what's coming, am I still waiting for an assessment while struggling with my mental health, which I feel is mainly due to my untreated ADHD?
Yeah, well, first of all, sorry about that. There's nothing much we can do about it. The nature of these services is they started in 2013. And at that point in time, nobody really knew what the demand was going to be. So we had to kind of guess. The commissioners guessed. And so we had regular reviews at the early start of this period with commissioners to say, well, how's it going? And the referral rates to start with were 40 roughly per month. They're currently running at 120 per month. And so what you've had over the last several years, probably the last 5 years actually, is that referral rates are roughly 4 times capacity per month, every year. And so that's why you're waiting, is that because this is a service which the demand has far outstripped. And I'm not going to, and I suspect you're not surprised by that, is that we are we're basically facing the outcome of people having opened a door, people have walked through it, and suddenly people have realized there's more to it. The service is not meant to replace mental health services, and that's the crucial point, is that if your mental health has got worse, treating the ADHD may help, but it also may need your mental health to be looked at separately. And so from that perspective, I would still suggest that seek support from GP. If needed, be referred to a mental health team. But we'll get to the ADHD as soon as we can. And all I can do is apologize for that, but it's not something any of us like, but that's where we're at.
Next question, which is, why isn't there any form of specialised counselling for ADHD adults? We suffer with anxiety and depression and other mental health issues, and there does not seem to be the help for ADHD adults.
So again, the key thing in that was mental health. And mental health services are commissioned. And there is mental health counselling available, and it depends what you mean by counselling. Again, counselling says a lot of stuff, from psychodynamic psychotherapy to CBT to just basic psychoeducation, and different things do different bits. We've developed within our recovery college model a little bit of psychoeducation course, so that is, in a sense, how to live with it. And there was a pilot study done by our psychologists that hopefully will expand out. That will hopefully, if everything goes planned, be available in the recovery college. So that's our offering. Then there is the bit that is available through IAPT already, in terms of the brief psychological stuff that exists, and the new GPIMS service, which is only just starting and getting off the ground, will offer a bit more of that. And so there are routes for mental health support around that. And if it doesn't reinvent the wheel, then let's not duplicate. And that's why I think commissioners are saying, well, actually, you already have bits. You need to access those first, and then specialists will do specialist. And so it depends, again, what is the issue around all that. And so that's where it's at for that.
I think it's hard as well, I've been into therapy not that long ago with my matters, and the first counsellor I met, I just didn't click. She just did not understand where I was coming from. I couldn't express myself. I couldn't, so I just sort of walked away and said, no, get me another one. And you don't want to go through that whole having different counsellors, because you just don't get, it's not about don't get on with them. They don't understand our processes.
And you'd argue to a certain degree that it would be consistent across the board. I think part of the issue is trying to get those primary care, because the way it is structured, okay, is the majority of resources given where the majority of people are. So the specialist services have much smaller resources. It's like a pyramid. And so you need to get the people at that lower end more able to manage this if we're going to deal with such big numbers. And that's the crucial bit. So if all the big numbers and the resources gone down there, then we need to get them better rather than saying specialist has to do it all, because then you end up.
In respect to maybe where they're coming from with the counselling, is that, you know, I said it in my last video that, you know, I describe it as a rucksack, and
Okay.
you go through life and all these derogatory comments and, you know, the words and the constant put downs are all put into this rucksack, and then you get given this new lease of life. You know, yeah, you've got adult ADHD, and after loads of misdiagnosis, you're like, oh, thank God. But you just carry in this rucksack. And I think that initially needs to be dealt with. And then moving on from there, you know, I'm studying to be a coach. Moving on from there, you have to learn about your own ADHD. You have to learn about your own brain.
Yeah.
You have to learn your triggers, and so much hard work goes into it. And I think so many adults get a diagnosis, get their tablets and go, oh, yay, I've got a magic pill and I'm going to be great. And then they go, well, why am I no further forward?
Yeah, I agree. And I talk about psychiatric onions, where you've got the brain underneath it, and then you have layers of life over and over and over. And what we're trying to do is to peel back each layer and work out which bit is doing which bit of you, who is the person who's sitting in front of us, and that we need to deal with. And that's where the complexity comes into it, because it ain't just about ADHD, it's about ADHD or your neurodevelopmental condition and life on top of that. And yeah, so I completely get that. And the fact that you were missed as a kid, then the fact that you're blamed for being lazy, or you're not doing this, and actually you struggle in these areas and people don't put accommodations in for you like they would now, hopefully, that those kind of things make your self-esteem reduce, which is layer on top of layer on top of layer. And that's a complex trauma we talk about in these kind of situations. But underneath all of that is your brain, your neurodevelopmental condition, how you function. And then if you don't understand that in the context, you don't understand the layers, because you have to understand it all together. And that's what we want to try and get to in terms of developing, but that's probably the next phase of service development, because that isn't currently something that we can deliver, because it just isn't resourced.
No, it's not. I mean, the same with coaches. You have to pay for them privately. You have to, you know, we're not cheap. And, you know, that's what you have to do. But you seriously have to sit. I took my tablets first. I've been diagnosed 6 years. Took my tablets, and about 2.5, 3 years ago, someone said, oh, you know, but you really need to understand your own ADHD. I was like, no, I have medication for that. I don't need to go there. But then you do. You know, you suddenly realise, look, I'm stuck. I'm not moving any further forward. I need to sort out my head. I need to sort out my brain. Yeah, it's
one of those things. You know, I've got mild visual processing issues. You know, it makes me mildly dyslexic. I'm not dyslexic in terms of major problem, but obviously I've studied, I've become a doctor, I've done a PhD level sort of study, you know, published over 60 papers. You know, it's not stopped me, but I understand my limitations. And that's, I think, what you're talking about, is you need to understand the limitations of who you are and what your ADHD allows you to do, and where you need to scaffold yourself in order to make the best of who you are. And I think that's the same for all of us. And that's hopefully partly why we try and want to be able to offer that bit of it. But it's a challenge to get all that, and the wider world doesn't understand all that sometimes. And so, yeah, I get that.
Yeah, it's pretty hard. The next one is standard CBT didn't work for me. I need something else that works with my type of brain, but it doesn't seem to exist. Are there any other accessible therapies?
Well, it depends on how the approach of CBT works, and everybody is subtly different, because no two people with ADHD are exactly the same either. And I think that's the thing to bear in mind. So we've thought more about a psychoeducation type route to start with, and hopefully, as I've said, the pilot project worked well, and we're trying to get that within our recovery college model. And so that will be broadly available. But it is an education thing to do. What you talked about is about how to understand your ADHD and how to be able to live with it. So it then comes back to, well, why are you having CBT? What was it for? Is it for a mental health thing, as we first talked about, or is it for something else? And each bit will have a different narrative and a different presentation. And again, if you've got comorbidities and overlaps, again, it will differ as to why you may or may not. So there's no one size fits all. I think that's the subtlety of this. And that's where you need to understand the individual first and then direct them to the right management strategy. And I think that is not something that we clearly have easily available. So some people will need longer term work. We can do a maximum of 10 weeks. That's not enough. And actually, for some people, that's more harmful than it is good, which is why we've stopped doing things unless there's something that can actually be beneficial in that period of time. And really, it's just a brief education course. So then what you're getting into, well, how do you get those other things? And that is a challenge. And that is the discussions we're having now about how do we fill those gaps that don't currently exist. And I think a lot of the problems, and I suspect some of your other questions are going to be about, I want this, I know I need it. Well, actually, we all starting to realize, those of us who work in the area, that there is a gap. And slowly, step by step, we've been filling the gaps, but that doesn't mean that there aren't gaps left. And each time we've identified a gap and tried to fill it, it's kind of opened up the door for the next big gap. And so I suspect when we fill the next gap, there may well be something else that comes out, because you suddenly realize, oh dear, we've missed that bit. And
Yeah.
You know, but we're slowly trying to fill that in. It's like the jigsaw puzzle, isn't it? You know, there's that one bit missing and you can't find the piece and you're trying to fit it in, but slowly we're trying to put it all together.
Yeah, and I think, you know, like I go back to, you have to, even on my course, you know, I'm learning the way I process things, how I learn, putting in boundaries. I've never had a boundary. My kids have never had boundaries because I was so disorganized. I do now. But, you know, what your tolerations are, what your, you know, you've got to set limits and you've got to understand, you know, the way your brain works. I'm now looking into maybe trying to come off medication. I shouldn't be saying that to you because then you might discharge me. But I am looking into it. And yeah, so I've now got high strength, you know, vitamin D, obviously, magnesium, zinc. I'm working with Ecrizin with the omega-3s, the DHA, and the other one, can't remember the name of it. And working that side of it, because we all look after our bodies, but we don't think about looking after our brain. You know, so I think, yeah, looking at different avenues and just doing research is this.
Okay. So there's no one size fits all with medication either. You know, the most straightforward individual with ADHD will probably respond to a methylphenidate based medication, and will be low level and be fine. Others won't. And that is the thing. And having more routes which you can go down to treat people, the better. Does everybody need medication? No, you can learn to live with it without that. There are people who have chosen to do that, and if that works for you, then great, because effectively there is no such thing as side effects that are just effects. But if effects at all different parts of your body, you know, that's going to then be interpreted by in other ways as having bad side effects.
Yeah.
And you can't take a medication that's going to have an effect which isn't also going to have side effects, because you don't want them, but it's the way they work. And so if you can not take something, get the same outcome and the same output, because that's the point, is you're trying to achieve something. You know, you've said it several times already, you did something in the past, you functioned in a certain way in the past, now you function differently. You've told me in yourself several times is that you wouldn't have set up the charity and run it if you hadn't been treated and you hadn't been diagnosed. And so for you, that's changed your life in that sense. And so that is the key. But are you in a different place now? Are you somebody who knows more about themselves and you can now think about coming off medication? We would always encourage that, with a proviso that should you ever need to go back on it, then you know it works and you can go back on it.
So get to the back of the queue.
Well, that's the point why the whole thing has to change, because actually, do you know what? If you've been, let's put it this way, okay? You're diagnosed, you've been treated, you know what works for you. Why, if that's the case, you don't do the baseline checks, you don't need to be diagnosed again,
Right.
you know, unless things have changed massively. You know, we would argue that somebody like yourself could go back into primary care and your GP could restart that with a little bit of advice and hand-holding if needed. And once they get more confident, they could do that. And that's what's happened in several cases across Surrey, where people have come in, they are waiting for a long time. And some GPs are willing to work with us on this. The advice and guidance gets a response within 2 weeks, never mind 2 years. And if they have been diagnosed and are restarting medication, some people have restarted it with support. And for you, in that scenario, that would work. Because we know the issues, we know the risk factors, we've been there, done it, tried it, and you would start with what you were on before and see how it would work and go from there. And if it isn't working, then you go back into the service. But then that frees up a huge chunk of people who are waiting, and so allows the capacity to work efficiently. And so it's the system, I'm saying, which needs a thorough rethink. Not
complete
just
rethink, yeah.
And it's not just about everything has to be specialist, because if everything has to be specialist, it's not going to survive. And I've said this, and I've said it in many places, I don't think services are sustainable if it's only specialist services.
I mean, I did share it to the group actually. So I follow a lady on Facebook called Laura Cleary, and she's in the States. She's a comedian, and she's married to an Englishman. And anyway, she's an ex-drug addict, he's an ex-alcoholic. And she always knew there was something wrong with her brain. So she went, I mean, they've got the money, obviously, to do it. And they went to see a doctor called Dr. Daniel Amen, something like that. Wow, this guy's amazing. And they did fMRI. And just even looking at the images of someone who's an ex-drug addict, it's like their brain is full of golf balls. It was just bumpy. And they showed which parts were sleepy. Obviously, they were both diagnosed with ADD. But you could actually spotlight which parts of the brain. And this is my argument with medication, which lovely medication nurse Surrey knows me too well. I go in there and go, no, but and I've said to you before, what parts of the brain do different medications target? And surely to get optimal results with medication, you need to find out which bits are sleepy, no?
Yes and no. It would be nice to have access to functional imaging and things like that, but you're never going to get a real life functional center, and because what you want to see is what your situation is like in your setting. So when it's quiet, you're in a quiet room at the moment, you've got no distraction.
I'm in my shed.
All right. You're in your shed down there in the bottom of the garden. Okay, in the shed. Okay, fair enough. But the point being is, that situation is different to a work situation in an open plan office where there's lots of noise and other stuff going around. You want to test that person in that situation. fMRI won't do that. fMRI uses what we call the BOLD technique, which is about blood oxygenation. It's looking at how much oxygen comes out of your brain as it's using, and the changes are what's doing it. It's looking at different parts of the brain, but it's also about integration of how the circuitry works. And so it's a combination of all the different bits together. So the imaging gives you a certain thing, but in its own right, it's not enough. You have to talk to the person. And one of the things that we're good at in the UK is to treat people when we can try and work out what's going on and titrate it to people's lifestyles. And so, America likes technology. It uses all the stuff, and it's great if you've got it, but you don't have to have it. There's sometimes where I think people use things to overkill where they don't need to. And so you get every test available because it's available doesn't mean you need to do it. One of the things that you learn to use in a resource limited is what the things that are required in order to help support the individual. So the place where I would restrict that for is where there's the most complex, you're not understanding and it's not responding. And so does everybody need everything? No. Does some people need everything? Yes. Do you see what I mean? And again, it comes back down to who needs what when. And because, we do understand the kind of pathways that are involved in most cases, but it is to do with how these things interrelate. So there's also that whole link, my interest in the causes of these things as much as the outcomes of the brain damage. And that is why actually, if you understand the things that are defining that, you can start to predict what you're likely to see. And so those are the kind of overlaps. So if we had it available, would I love to use it? Absolutely. Do we have to use it in order to treat people, make them better? No. So that's why I say a bit of both.
Yeah, I mean, I did start off on non-stimulants because of my past, and on non-stimulants because of my past. And so I started off in Strattera, and it was fantastic for my brain. I could really work with it, but it wasn't good for my body.
Mm-hmm.
And I find, so I'm on Elvance now, and I find with Elvance, it actually blocks creativity. Mm-hmm. It doesn't let me be creative. So I have to be creative at like 11 o'clock at night. It's wrong. It also, so, I study in the States, and my classes are 7 o'clock in the evening. So I have no medication in my system. So what I've done is sort of done a top up late in the afternoon. So then that carries me on. Mm-hmm. I've now had to stop that because I can't learn while I'm on Elvan. It's weird. It's like they must target different.
Well, it's dealing with a range of things. So they're all chemicals, and they're dealing with the neurochemicals. We know the pathways where the neurochemicals work, and we've got the understanding of how they're going to function. Most ADHD, all of ADHD, in fact, is actually looking to modulate the sympathetic nervous system through noradrenaline. That's the primary route of what we're trying to get at here. And by modulating that, what you're doing is to make you more alert, more concentrated, less hyperactive, because you're ready for that big monster to come out and bite you. And that's what you're trying to do. That's fight and flight comes from. That's why the overreaction to spiders is because all of a sudden your fight and flight kicks in, and then you panicking because of that. Your heart rate goes up and other stuff. That's why blood pressure is such a big thing with this. It's not going to be as potent. So Elevance works on both dopamine and noradrenaline reuptake, but also releasing noradrenaline. So it's basically giving you all three kicks, whereas methylphenidate is working primarily on the reuptake. If you're treating with Strattera, it's again noradrenergic, but it's working in a different way. So it's more like an old antidepressant, which is working on a different kind of aspect, and so isn't a stimulant in the same approach. Guanfacine Intuitive is another one which actually works in a different mechanism, so you can start to combine these things and tailor it to the person. For you, because your course isn't forever, you'd be talking to you about your lifestyle and thinking, how can you use it? Where could you modify it, take it at different times? So shift working is actually the hardest way to treat, for example, because there's no consistency. And so you have to try and use it at a time where the peaks and troughs of it. But actually these medications, which I really enjoy, is if you understand the profiles of the medication, you can try and titrate it and tolerate to somebody's lifestyle. And so you can work it to say, right, this is your lifestyle. I know this medication works in this way. I'm going to use this one because that works here, compared to this other medication, because actually its profile is different and wouldn't suit your life. And so you can start to say, actually, what's nice about them is that we are now tailoring the medication to you based upon understanding that broader profiling.
Yeah, and I think it sort of maybe goes back to the whole thing of learning about your ADHD. On my course, I'd never heard of the words cognitive hyperactivity. Okay. I was like, oh, what's this? New shiny. You need to have a research on that one. And I think that maybe the stimulants that I've been on have actually caused cognitive hyperactivity, where it's just too much. Do you know what I mean? I can't sort of filter it out.
Yeah.
But now I've learned about my own ADHD, I can actually go, well, hang on. Let me just think about this a minute. I'm being impulsive, or and it's just made such a huge difference. And the decrease in the dosage as well, because I've just learned about my own brain. It's not rocket science. Well, it is actually. It's not easy.
Well, it's one of those where actually, it is about understanding what you're dealing with a view to getting it right for that person, because no two people, like I've said, are exactly the same, and they need to be tailored to what you're doing and what your lifestyle is.
Yeah. and there's zero support post-diagnosis. I'd like other options to be made available, especially for those who medication doesn't suit, plus some follow-ups, not just here's your pills, have a nice life.
Okay, there's a lot there, and there's several questions in one, I guess. The fobbed off bit, hopefully not, but you know, it's one of those situations. Psychotherapeutic invokes work for some, it doesn't work for everybody. Now, the problem is, you know, yes, it is a medical model approach, and there's no doubt about that, because we are giving you a drug to try and treat it, but that is the bit that you need a doctor or a nurse prescriber for, because you know, you can go and see a counselling psychologist, you can get IAPT to do some of the other bits, and like I said before, we weren't commissioned to replace things that already exist. And that's the point. No commissioner is going to pay for something twice. And so at the moment, you should be able to get some basic therapy and other bits and pieces through primary care, existing psychological therapies. And that's part of the problem. Not everywhere feels comfortable with it, but but it can offer some of that. Now, the other bit around what we're trying to develop is understanding that those recovery college bits and the psychoeducation parts are important, but we need to get a model right to be able to deliver that, and that's taken a bit of time. But that will be available. If you have to choose, and there's limited money, which is what there is, between offering psychological therapies or the monitoring and managing the medication, well, actually the medication has some of the most effective drugs out there in terms of their benefit for the condition that we're treating. There's this thing called number needed to treat, which is how many people you have to treat before you get a beneficial effect, and these are about 1.5, which is really, really impressive in terms of their drugs. They work really well when they're going to work, and that's why you know, the focus has to be on medication, because that's what a hospital medication secondary care service is meant to do. And so it's not about fobbing you off. If we had the resource to be able to deliver everything, we would. I think there's a misunderstanding out there broadly, thinking that we've got loads of medication that we're sitting on our bums doing nothing and not wanting to do it. That's completely wrong. You know, we would love to deliver all this stuff, but we can't, because we ain't got the resource to do it. And you know, there's a few of us trying to do a lot with very little. And that is the challenge. Hopefully that will change with time as people start to wake up to some of this. But like I've said, it has to be a whole system change if it's going to be sustainable. And the problem is, when I said it was new, you know, we've been going since 2013. There's still a lot of services around the country that don't have anything, or they're only just starting. And so in a sense, it is waking up to what is the extent of this out there, with a view to trying to make a difference going forward. It can take 10 to 15 years, unfortunately, for the significant change to happen. So you look at a service then, you look at a service now and say, oh, that looks different. But that's how long it takes to embed in. You have a 10-year plan for the NHS, ADHD isn't mentioned in it. So, and that's the thing, is neurodevelopmental autism is, learning disability is, because that was a problem 10 years ago.
And I think as well, you know, can I just say that there are some really passionate doctors and nurses in Surrey, you know, yourself and Paul and people like that, that are just working so hard. And I think a lot of this revolves, I don't know if you agree, just revolves around the whole stigma of ADHD. The minute, you know, I've been doing a few tests here and there, and I said to someone one day, I think I told you the story, I rang up about council tax. So I was like a couple of payments behind. It was ridiculous. And my husband always deals with the bills. He was having his leg amputated at the time, and said, all you have to do is pay council tax. That's all you have to focus on. Of course it didn't get paid. I'd rather go and spend it on something else. And I just completely forgot all about it. And then I was threatened with court and just God knows what. So I was in the office one day and I rang up the local council, Spelthorne Borough Council, and got this chap at the end of the phone. I'm trying to explain to him, and he said, well, you've just got to pay it because you've got to go to court, and now you've got to pay the costs. And this, I said, hang on a minute, I'm trying to explain to you why this isn't any excuse, but my husband is in hospital. And I said, you know what, I wasn't going to mention it, but I'm going to. And I had this chap on speakerphone. And I said, look, I'm really sorry, I've got adult ADHD. It's not an excuse as to why I didn't pay it. It's just a reason, right? I completely forgot. well, he just went quiet, and then he started shouting like, "Oh, okay." I said, "Mate," and I let him go on, and then I said, "You know what? I'm not deaf and I'm not stupid. I'm actually very intelligent, and you're talking to me like I'm a complete idiot." And they just weren't having any of it. I've said it to people face to face, you know, "Oh, sorry, could you just explain that again? I've got ADHD." Or he goes, like, I've said something really awful, and you just get these raised eyebrows or a tut, or, you know. But then I actually said to someone, I thought, I'm going to try this a different way. So I said, "Oh, sorry, could you explain that again? I've got autism." Completely different reaction. Completely different. They couldn't have helped me anymore. Why do I have to lie?
Yeah, and that's the problem is
Or actually go to the root cause of, you know, if they need a sit-stand desk or whatever, they could be a kinesthetic processor.
Yeah,
So
absolutely.
that's why they need it. Or,
Yeah.
you know, go back to the root cause of the problem and find what their processing modalities are, and then you could probably adjust. You know,
That's the point about the individual.
Yeah, exactly. And I think, you know, when we did the umbrella project at Heathrow, and I was speaking to one of the managers, and he said, "Yeah, I've just employed a girl with ADHD." And I was like, "Wow." Like, you know, what advice did you get? Support? He said, "No, I asked her, what can we do for you?" I was like, "Oh my God."
That's very informed. It's very good. That's exactly what you should do.
Yeah,
Just find out about what the person's needs.
Yeah, and she said, if I'm in a meeting and, you know, you want me to take notes or whatever, if I just get up and start walking around the room, but I'm still writing, I'm listening. I just need to move around to process. And he was like, "Yeah, that's fine."
I'm a kinesthetic learner. I used to, I think better when I walk. If they make me sit still, I hate it. This is a wiggly chair. You can see I'm wobbling around because I prefer movement. Yeah, but I prefer that movement in order to function. You know, in the olden days when we had tape machines, and you laugh at this, is I used to do a lot of my dictation late when everybody left the building. I was the last one in. I'd walk around the entire building because I'd think better. And you know, it's one of those things is that people have different ways of functioning, and you should ask what they need to get the best out of them. You know, the more you inhibit them, the more likely you're to get a negative outcome. So that's what you started with, saying understand your own ADHD, understand your own neurodevelopmental condition.
100%.
And then you can tell other people what you need, because that's what's important, because it doesn't matter what you need because you'll be different to the person next to you. And that is the point. Your ADHD and your experience is different to somebody else, but there will be overlaps. There'll be things you can learn from each other, and those general things, but then the subtleties around the edges will vary, and that will change based on who you are. And I'd rather focus on the individual, and I think that's the problem I have with a lot of the assessments where it's done very quickly, where you don't think about that. You never pick the individual out of it. Just saying you have ADHD without understanding what's behind that in your profile means what you're treating. You don't know which bit you're going to try and help. And that, for me, is where quality is lost sometimes, and why we want to try and make sure that we've got enough.
I mean, Heathrow are absolutely amazing. I'm going to be interviewing Jenny, who was a volunteer of ours, and she was actually, you know, she developed the Umbrella Project at T5, and she's ADHD and dyslexia herself, and she's now disability lead at Heathrow. And they, well, obviously not at the moment, but they were before lockdown, really high on employing neurodiverse people, and, you know, letting them fit in and working with them. And they're amazing over there. They put so much in place. But like I said, it's not, we can do this for you. It's what can we do for you, which is, they're two completely different things. And that's massive. That's like, you know, someone came to me and said, "What, for you to fit into this workspace, what can we do for you?" I think I'd fall off my chair. Also, even to reduce stigma, it's just, I was talking to my coach the other day about this. I hate saying that word, ADHD. It grates on me. I hate it. And I think this is maybe where the stigma is coming from, because at the end of the day, we don't have a deficit in attention. We just have trouble regulating it. We don't have a disorder. We're actually quite knowledgeable. We just can't put it all together and make it happen.
but then you're perpetuating it, because why should you be ashamed of it? You've got something same as anybody. Lots of other people have
Oh, I'm
different
not
things.
ashamed. I just don't like the word.
Yeah, I didn't come up with that. So, there's a lot of words you'd probably change. Call it Fred if you like, but sort of
I'll call it what.
yeah, but exactly. But the point being is that, it is what it is, and we just have to accept it. And stigma reduces us, because stigma exists because people don't understand it and they're fearful of it, and they think it's something when it could be something very different. And so that only gets changed by us challenging it. And it changes through that. So there's a lot of work that's going on. So you wouldn't have had royals going on, so with Prince William and sort of Kate and Harry going on about mental health and stuff, and that raises the profile. Like royals or not, it's irrelevant in a sense, as they are helping raise a profile of mental health in this country. And that's really good, because it destigmatizes it, because it normalizes it into a situation where people can have that conversation and say, do you know what, yeah, I was ill for a while with depression, or I had an illness which I needed to take some time off, or whatever it was. And people can say, I've got a neurodevelopmental disorder, I was born with it, or it's not my fault, I just have it, and so I've just got to get on with it, and I need to learn how to live with it. It goes back to what you said right at the start. Learn about your own ADHD and your own self. And those are the kind of things that we want to be able to do.
I think I'm more sort of frustrated where I'm learning, obviously in America, and everyone's American, funnily enough. But I'm the stuff.
I wouldn't hold it against them.
But the stuff is off the scale. There is not one thing I think that I've heard before. Like, I've been in this business 6 years. I've been working in this industry 6 years. I've heard it all, and it gets to the point of, oh, here we go again. Just the same. Let's find something different.
The thing I'm going to say to you is that you're on a specialist course, yeah? So you're going to be taught by the people who are the best in the business, probably.
They're best in the world.
Yeah, so there you go. So you're going to hear stuff you won't have heard before, because they're going to tell you that. You go to your average bod on the street, I can guarantee you they won't be as knowledgeable as the people teaching you. And it's no different here. You come here and you will find people who are experts in the field as well. But they will be a handful in terms of who are at that kind of level. But there are people at that level in the UK. I think the UK is a really good place for science and for developing it. And actually, we can balance out the States, because we're not all about everybody has to stick everybody in scanner. It's about thinking about the societal aspects, the individual aspects. And so you bring something different to the table. But you've got really good people here. But I bet you if you go around and you talk to people on the street rather than just on your course, you'll have the same kind of issues.
Yeah, I'm not just saying, it's the States. I think when we go
everywhere.
It's everywhere. And, when we go back to the whole ADHD thing, they don't just have, so here we have inattentive, hyperactive and combined.
Yeah.
Right. So that's 3 different forms. Over there, they have 7. And
okay.
If you actually look at them, so one of them is called limbic ADD. So it comes from the limbic system, and it's all emotional. Now, you could target that with a specific medication, because you know what medication is going to target the emotion side of ADHD. So do you see what I mean? It's broadening the scope, but also letting you optimize the medication or treatment that goes along with it.
Okay. The only caution I have about that kind of stuff, and I don't know about that as much, so I'm not going to try and pretend I do.
I haven't researched into it. I just heard it on YouTube.
But the thing you have to be slightly careful about is then bringing in everything to say, right, everything's now ADHD. All the limbic system difficulties are part of ADHD. All the bits where it's not. It's a brain-related issue, and it may actually overlap with lots of other conditions as well. And I don't know that.
There's big talk at the moment, like especially on the adult pages on Facebook, about RSD. Mm-hmm. Rejective sensitivity disorder.
Okay.
And why it's not in the DSM, because it is a massive, huge part of ADHD.
Right.
Massive. It has I suffer, used to. No, I still do. That's a lie. I do suffer with RSD, absolutely horrendously. I seem to have put a lid on it because, again, I've learned about my ADHD. But, yeah, rejection, it hurts physically.
So the thing that I would say to you about that is, what is the brain and what is core, and what are those overlays? if you see what I mean. So there was a debate about should you have behavioural issues or sort of the behavioural modulation part as part of the diagnostic criteria. The problem is that can be caused by so many things, and it can be about experiential, and that's the complex trauma aspects that get laid on top of it. And actually, what should be core are the things that you have to have, and those other things are comorbid outcomes in people that are common to it. So they're associated. And so you have to differentiate, in my mind at least, which are those things that you commonly see but aren't diagnostic and they're not core, and those bits that you'd expect to try and manage, and how does that differentiate between your experience of ADHD from somebody else's. And it's not to say it's not valid, and it is a comorbid presentation, but what's leading to it is that your experience of life after you've got ADHD. So that's layers, if you see what I mean. And so that is something slightly separate to it, even though it's a common presentation within it. Do you see what I mean? Try and get at.
Yeah.
And I think that for me is where we need to be more sophisticated in how we understand some of these things. Personally, I'd prefer us to get to the point where we understand the brain and we deal with behavioral neurology and understand this bit of the brain does that and that's how it works, and therefore we can treat that. That's going back to your fMRI stuff, but it's not trying to label it within a condition. It's understanding a bit like neurologists do, but we're dealing with the behavior side. And that's a long way to go before we get that, and you may not get there by the time I retire.
Yeah, I mean, that goes to sort of the last question, which comes from me.
Okay, you can always have that.
So if I'm at the point, like I said, about the medication and things like that, and the fact that I've learned about my own brain, I'm at the point I want to go further forward with it, and I want to do more research into my own brain and what medication targets what parts and what parts aren't working in my brain, because there is something not working, but I can't pinpoint it. I don't know what it is. And if I went to my GP and said, okay, I want to get an fMRI because blah, 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 would I get it?
No.
Why?
Because it's not easily available. In this country, it's still mainly a research tool. I don't think it's used as clinically in a lot of situations. It is available in certain places. If you were part of a research project, you could probably get it. And so it's looking at saying, well, where are these things available? Clinically, it's not used routinely. And the States, remember, is different. They've got 5 scanners for every the hospital. Even the small backwaters have got MRI scanners who can do everything. We don't have that, and so it is not something that is routinely used in those kind of situations. If you're part of a research study and there are people researching that, then yes, you probably could, but it would depend on what they're looking for within the context of that. And again, the thing about fMRI scanners now, you sit in a scanner, you get shown a series of tasks, and your brain lights up with stuff, but it's limited as to what you can do. So it's not going to tell you how you're going to function down the shops when it's noisy and busy, because you ain't going to walk around with this big scanner on your head with a magnet weighing several tons, because it just ain't going to happen, is it? And so that's the problem. And so that's the nature of it. It's limited as to what it will tell you. Tell you some things, but it won't tell you everything. And that is my point that I made before about differentiating what do you need to do to get at the diagnosis and what actually helps. And the most complex groups may benefit from it, but a lot of people, it's an excessive way of doing it. In America, you get everything. If I'm being cynical, there's an element of insurance and what you're going to pay for and stuff like that. Here, slightly different. This is going out on the web, so maybe shouldn't have said that, but never mind. But it's one of the, but the point being is I love the NHS. I only work for the NHS. I don't do private work, because the fact is everybody gets a free service, but it is limited in the resource that it has. So you have to be vetting what you need and what benefit you're going to get from it and how it's going to impact on you, and describing people's lifestyles and getting an objective history of what you want allows us to titrate to you, in theory, compared to somebody else. And that's what we do day in, day out without doing an fMRI. And so is it useful, and would I love to be able to have access to it if it was there? Yeah, I'd love it. But at the moment, it's not at a level where it will give me all the information to tell me about your lifestyle in every situation you're in. And that's therefore more of a challenge, because it will differ from in the room.
I think I'm just, because obviously I'm studying in the States and finding out the stuff
Hmm.
that I've never heard of here. And it's just like the penny drops. You just think, my God, we are so far behind. Or, you know, I'm on the
No,
fence about it because there is this whole thing about overdiagnosis in the States.
I think the thing is that in the specialist centres like the Maudsley or down in Sussex or whatever, where they've got the scanners, even in Surrey, you know, they could probably do that, but it would be research from a lot of it. You know, in some situations, for example, in dementias, they start to use it as scanning and other things a lot more. And so they're ahead of us in that sort of thing. But for what I want to know, if I was going to use fMRI, I want to see it in a functional situation in terms of what you're doing in different situations. That would influence my clinical practice. And that is something that we need to think about to start with. But the scanners don't allow us to do that yet. So how much extra is it going to give us? It's not diagnostic, any of this. And so it's not going to add to that. It gives you extra information, but it's not in itself what gives you the answer. Just because you have a deficit in one area, well, there's lots of things can do that. And we still don't fully understand how the integration of the pathways fully work. And so, like you say, it's exciting stuff. We're learning all the time from them. And the stuff that's happening here is teaching them as well, because we all learn off each other. But you know, there's still a way to go before that becomes routine practice.
The whole thing about, you know, women, it really needs to be brought to attention. And I'm not being sexist, but it does. And, you know, women of my age, we're in perimenopause or we're going into the menopause. So, you know, I have a hormone tracker, I have, you know, a PMT tracker. So I know when my hormone tracker tells me, it will flash up on my phone like, oh, it's day 15. That means your estrogen has gone through the floor, love. You've got to go find it. It's disappeared. And, you know, all these women come out saying, oh, yeah, I'm going through menopause and cognitively I just can't think straight and I can't do this and I can't organise everything. And you just think, my God, we have that anyway. So then going into the menopause where your estrogen is on the floor and your medication does not work whatsoever. I'm lucky in the respect that Paul trusts me to adjust my meds over the month because he knows. And I said to him, it's not working. It's not working. Like, it's ridiculous. So he's allowed me to do that. But it still hasn't made a huge difference. So what, going forward, is there going to be more work with women and hormones and medication? And what do you do in your clinic, Raja?
Well, in terms of hormones and medications, we probably don't do a huge amount of it because that's not what we've got access to be able to do. We need to be able to do that kind of stuff. You need to have the access to labs, to the other bits and pieces, the research and the other bits. And you know, we're struggling just to keep on top of it, as you've heard many times, with the basics, never mind the really complex stuff. If you get to the point where the 1,200 people are being seen, and we've got that sorted and we can start to do the really specialist stuff, which includes research, working with sort of universities where they will do it, because the universities is where they're going to do it. I presume you're being taught through university, which will be the specialist centre, and so they'll have access to all the data. Well, we're not linked to any university, we're just a standard clinic. You know, if we can do that, then we can link in and start to do the extra research and the other bits. Great. But
I mean, that's, you know, that's not coming from the States. That's actually coming from adult groups that I'm on Facebook, and all the women are just like, I'm coming up to the menopause, nothing's working.
So what you're raising is a question, and when you've got a research question, what we do is that we try and sort of find out ways of getting it. What you're describing is you've got a population that could be studied, and so then what we need to do is to sit down with the universities. And so University of Surrey have got an ADHD interest, but mainly in kids, but so we can easily sort of try and expand it out. We would meet them and go and sit down and say, do you know what, we've got this question, why don't we look into it? And then we would come up with a way of actually getting that funded and looked into. There are other specialist centres around that could do that kind of stuff as well. But it's, as an NHS clinic, it's only by joining up with those specialist academic centres that those kind of questions, that specialist stuff that you're talking about, is going to go from being the research question to a clinical thing. And so then when it's been proven this makes a huge difference to clinical practice, will it get embedded into it? Right now, there's the resource to just see everybody, never mind do all this other stuff. And that is the fundamental problem with it, is you're just trying to do the basics. And, you know, we're trying to do as good a quality. So our main investigation is using QB testing, and so that's something where we've got a little bit of investigation we do, because we can show clinically it has a real impact on some of the things that we're doing. The other stuff is interesting, but hasn't been proven yet in terms of cost effectiveness and availability, what difference it's going to make hugely yet to do that. Once it is, yeah, we'll use it. And that's the thing with what you're saying, is you're identifying a population where there's a problem which hadn't been looked at before, possibly. And I'm going to be honest with you, I've not looked into it, so I don't know that bit of it.
There's not a lot out there, Roger. I watched a webinar with Dr. Sandra Coogee the other night about it, and it wasn't long, because there isn't hardly, she said more research needs to be done into this, because women, more and more women are coming forward with ADHD.
Then if we've got a population of people and there's that here and it's accessible, then the question would be about me to getting the research partners to do that and take that forward. Talk to me offline and we can
definitely
think about.
Yeah. Well, thank you ever so much, Raja, for answering all the questions and agreeing to chat with me. And yeah, we'll chat offline about research.
Okay. All right. Take care.
Lovely. Thank
Bye-bye.
you. Bye.
Bye.